What I will try on today's lecture is to define what vitreous hemorrhage is, to talk about the etiology, what are the mechanisms behind it, what are the causes of why it occurs, um, what happens to vitreous hemorrhage, that's the fate of vitreous hemorrhage, how does one evaluate it, and thereafter how does one manage it. I will apologize at the beginning itself because there will be some overlapping and some repetition among the slides. Uh, some of these will seem that he just said that, he just showed the photograph. So just pardon me for that because this will happen in this presentation. Manish, are we on the next slide?
No, sir, it's the first slide.
What is the slide show now?
I feel you should take 2 minutes, switch off your computer and switch it on again.
Yeah, it's the same slide, so the vitreous hemorrhage topic slide.
What does it show now?
No, sir. No.
We are still on page 1.
No, so second page has come.
This is second slide.
Yeah, second slide has come.
Abaya.
But now it's not in a slideshow mode.
So I think we forget that. Let's keep it like this and let's go ahead at least. At least we can see it over here. Can we read it carefully? Can we read it clearly?
Yes, sir. Yes, sir. It can be seen clearly.
It is visible, sir.
Now? Manish, do you see the third slide?
No, it's a second one. That today define etiology and mechanism and cause. Second slide is visible.
So you still can't see the third slide?
No, this is still the second slide.
The today is still showing.
Yes.
This is a problem.
पूरा ऑफ करके फिर से ज्वाइन कर लीजिए, कोई बात नहीं है, हम लोग वेट करेंगे 3-4 मिनट.
Sure, sure.
पूरा कंप्यूटर ही शट डाउन करके अब तब फिर स्टार्ट. Let's do one thing. Pranab, you have your presentation ready?
Yes.
Dr. Pranab?
Yes, yes.
Okay.
Can we just reverse the order? Can we start?
No, not an issue. But is it shown now?
No, sir, no.
What do you see now?
No, sir, nothing is visible.
Okay, Pranab, start please. Pranab, start please.
Okay, sir. Thank you.
अपना पूरा कंप्यूटर ऑफ करके ऑन कर. Dr. Saurav Sinha, can Dr. Pranab start?
Yes, please, let him start. Dr. Pranab, please start
Yes,
your presentation.
I'm starting.
So Dr. Pranav is a consultant at Center for Sight, Kolkata, and he's a well-known ROP specialist in Eastern India. And today his presentation will be on retinopathy of prematurity screening and protocols and management. Dr. Pranav Das, please.
Yes,
Can
sir,
you
we
Yeah,
can
see,
see
we,
see
the
my,
slide. Yeah, we
can you
can
see
see
my
the.
slide?
Yes, sir, we
Very
yes,
can
yes,
see
nicely.
that.
yes.
Yeah. Good evening, my seniors and my colleagues, my friends. Next few minutes, I will be speaking on retinopathy of prematurity, screening protocols and management. Uh, can you see the second slide?
Yes,
Yes,
sir.
Yes.
Yes,
So the
immediately.
condition was described by Terry in 1942 as the retrolental fibrillation. At that time, they thought it's some kind of growth behind the lens. But as the disease was, the pathophysiology of the disease was understood, the term was later changed to retinopathy of prematurity. So, retinopathy of prematurity basically a proliferative vitreoretinopathy affecting the premature infants of low birth weight and young gestational age. So it happens in premature baby who are having low birth weight. Uh, Next, coming to the incidence of ROP, these are the three largest multicentric trial which have given us the insight of the ROP. What is the disease? What is the incidence? When should we treat like that? So if you look at the incidence of ROP, it's somewhere between 65 to 70% almost. So if you examine 100 babies, 65 to 70 babies will have some stage of ROP, but only a few, say 5 to 6% will require treatment. So we are actually trying to find out those 5 to 6% who require laser, and we have to treat those babies. Otherwise, there are high chances of these 4 to 5% babies going blind. So in India, the incidence reported incidence of ROP ranges from somewhere between 38 to 52%. Again, the coming to the international classification of ROP, this has been very nicely described disease. This classification is given by the ICROP group in 1984. They have described the disease as per the zone of involvement, like zone 1 to 3, stage of disease 1 to 5, presence of absence of plus disease, clock hours of involvement. So here we can see they have divided the whole retina into 12 clock hours or 4 quadrant. So we have to say how many quadrant or how many clock hours the disease involved, and we need to understand the different terminologies here. The zone one. Zone one is the central part of the retina. If you draw a circle centering the optic disc and the radius is twice the distance from the fovea to the disc, is the central zone or zone one. And if you draw the circle centering the optic disc touching the nasal ora serrata, you will get the intermediate zone, that is zone 2. And the rest temporal crescent is the zone 3. So here,
Dr. Sinha here.
yeah, yes, sir.
Can I request you? This is the for the postgraduates. This
Yeah,
drawing is the most important part.
yes, sir.
So my request is, can you just again repeat? Like for me, it's really obvious, but yes, the drawing of the fundus is with the center of the disc.
Yeah.
And can you again repeat what the distances for zone 1, 2, and 3? How does one define zone 1, 2, 3? Just go a little slow, please.
Yes, zone 1 is the central circle. Now, how do you know this zone 1? If you draw a circle, say from optic disc, the radius which is twice the distance from the optic disc to this white dot is the fovea. So that means is the zone 1. So if you, while you were examining, if you focus the disc at the center within 28D lens, the area you are seeing in a single go is the zone 1. Clear, sir? And the
Yes,
zone
yes.
2, if you draw a circle centering the optic disc touching the nasal ora serrata, that zone is zone 2. Now, there is a temporal crescent, that is zone 3. From ROP point of view, from clinical importance, zone 1 and 2 is the most important. When we call disease at the zone 1, that means disease is more severe. That means very small area of the retina is vascularized. So that we have to remember. Can I move forward, sir?
Yes, please. Yes, please. Please go ahead.
Yeah. So coming to the stage of ROP, now say there is no disease, but the retina is immature. There is no disease, but retina is immature. You'll see the gradual tapering of the vessels. We see mostly at the temporal retina, because temporal retina is the last part of the retina to be vascularized. Okay. So stage 0 is immature retina. In stage 1, we will see a line, a pen drawn line, which is demarcating between the posterior vascularized retina and anterior avascular retina. So here you can see a white line. This curved line is the demarcation line. This is the stage.
Can you please show with your pointer?
Yes, sir. Can you see my cursor? So this is
Yes,
the
yes.
line. This is the line. Faint line, but clearly you see the vessels are stopped here. All the retinal vessels stopped. This is the posterior retina. This whole part is the avascular retina. This whole part. Okay. So it doesn't have any volume. It is flat line on the at the plane of the retina. So this is stage 1. In stage 2, here you can see it got some elevation, some volume now. So you can see this line is little thicker here. Here you can see this one is the stage 2 ROP. So it has some width and height now. In stage 2, you will see another thing. There are some kind of grayish color, nodular, and some linear things posterior to the ridge. You can see this is the zone 2, and there is posterior to this, there are these gray color nodules like things. These are called popcorn lesion. These are the beginning of the neovessels actually. Okay. In zone 3, you will see these vessels actually moving towards the vitreous cavity. So along with the ridge, there is extraretinal fibrovascular proliferation. Here you can nicely see these vessels are actually elevated on the ridge. So this is stage 3. So along with the ridge, there are extraretinal fibrovascular proliferation, but the retina is yet flat. So this is stage 3. In stage 4.
Also, can we go back, please?
Yes, sir.
The stage 3.
Stage 3, sir. This is stage 3.
Yeah. Now, with your cursor, can you show the anterior retina in zone 3? The anterior retina with your cursor.
This is the avascular retina, anterior retina. This you cannot see any. There is no any vessel. Yeah, this is the ridge. This is the ridge. This is the abnormality. Main abnormality is here. You can see very obvious thing. Okay. And
even at this stage, we can make out that posteriorly the disc and the macula are reasonably okay. And this is a stage where if we can see this baby and, follow up, do treatment and see how things are going, we can very well save this eye.
Yes.
But this in another 2-3 weeks, if it progresses, will be a very tough job. Am I correct?
Yes, sir. Exactly. So our aim is to stop the disease here and intervene at this stage.
Right. Go ahead, please. Go ahead.
So in the next stage, the retina is detached. When the retina is partially detached, we call it stage 4. When the macula is attached, here you can see the macula. This is the macula. This is the temporal retina. This is the temporal retina. Here the retina is elevated. There is a partial retinal detachment 4A because the macula is attached. Here you can see this is the temporal retina. Macula is also detached, but the nasal retina is attached here. Nasal retina is attached. So this is called stage 4B. We don't want baby to reach at this stage.
Dr. Pranab, in this stage 4B, this disease is in what zone then?
No, it can be. See, here the avascular retina may be at the zone 2 or 3, but it is the retinal detachment. The vascular retina is detached here. Even if the retina is vascularized, the posterior pole is vascularized, that retina is detached. So, no point.
So, this is nearly zone 2 to zone 1 in stage 4B?
Sir. Here you can see it is zone 2 posterior disease. This white.
2 posterior disease.
Yeah,
because nearly from, if you see the in stage 4B, this photograph, the disc is there. If you see macula, then 2 disc diameter. So that where your cursor right now is, this is at the junction of zone 2 and go ahead.
Yeah, this part is zone 2 posterior. You could say this. Phobia is somewhere here. Okay, so and the part of the fovea is also detached here. You can see this. So we are calling it as a stage 4B.
Next stage, next slide, please.
So here the retina is totally detached. That's a complete retinal detachment. So this is stage 5 ROP. So you don't want any baby to reach at this stage. Clear, sir?
Yes, yes.
So the next most important thing is the presence or absence of flash disease, because we decide whether the baby will require laser or not primarily depend on whether the baby is having flash disease or not. What do we mean by flash disease? We mean if there is dilatation of vein and tortuosity of the artery. You can see this. Veins are dilated, arteries are tortuous. So at least 2 quadrant has to be involved with this. So we call it flash disease. Sometimes people is not dilated. This is called pupillary rigidity. That also a part of flash disease, and obviously vitreous haze. So this is the example of flash disease. In the left hand side photo, you can see all 4 quadrant is involved. In the right hand side, on the temporal 2 quadrant is involved with the flash disease. So there is recently this term is coined when the dilatation and tortuosity is not enough to call it as a flash disease, but neither normal, then it will be called as pre-flash disease. The implication is if you see a pre-flash disease, you have to examine the baby in short time, say 3 to 4 days or within 1 week. That is the importance of recognizing this pre-flash disease. Coming to the another variant of disease, this is aggressive posterior ROP. This is important as far as Indian scenario is concerned, because almost 30 to 40% of our babies are diagnosed with aggressive posterior ROP. Here, the peripheral disease is very ill defined. There is no line, no ridge, nothing. Only there are, you can say, demarcation vessels like this in the temporal retina, but the posterior pole, the vessels are very dilated and tortuous. The flash disease is disproportionate than the peripheral diseases. Typically, it affects in zone 1 and sometimes in the zone 2 posterior. Here you can see this. This the nasal retina, whole of the nasal retina is avascular. You can see the retinal hemorrhages. This vessels is grossly dilated tortuous. The very small part of the nasal retina is vascularized. The temporal retina, you can see hardly even the zone 1 is not completely vascularized. Part of the zone 1 is only vascularized. You can see this demarcation vessels like thing, but no line, no ridge, and there are pre-retinal hemorrhages. These are very common in aggressive posterior ROP. So coming to the most important aspect, ROP screening. Why do we go for ROP screening? It aims to identify those infants who have reached or have the potential to develop vision-threatening ROP. And if you look at the American guideline, you will see the guideline says that any baby less than 32 weeks, any baby birth weight less than 1500 grams should be examined for ROP. This is the Western guidelines. If you read the Western literature or book, then you will see this guideline. But in India, you will see, not in India, other developing countries also, many babies are actually larger than these. They require laser. So if you don't, we should be screening babies who are less than 2000 grams and gestational age at birth is less than 34 weeks, or larger babies at the discretion of neonatologists. So these are the two main criteria, 2000 gram and 34 weeks. We have to remember these two figures. This is the national guideline. When the screening should be begin, we should screen at 3 to 4 weeks of birth. ROP hardly develops before 3 weeks, but we should never go beyond 4 weeks. So screening, fast screening should be done at 3 to 4 weeks. Very small babies we can do at 2 to 3 weeks, but otherwise the first screening has to be done at day 30 of life or 4 weeks of life. How frequently examination should be done? It depends on what is the initial finding. If the very small area of
Dr. Pranab, sorry,
yes,
sorry
sir.
to disturb. Can we go back, please? Previous slide, please.
Yes, sir. Yes, sir.
Now, for the postgraduates, sometimes it gets very confusing: gestational age, preterm, actual age. So, from a very simple point of view, baby was born at 7.5 months, 8.5 months. Sometimes you'll have relatives calling you. You are a PG yourself. You're an
Yes, sir.
ophthalmologist, and some friends call you. I'm the postgraduates. I'm telling you. So just
Yes.
ask date of birth and say from date of birth at the 4th week this should be ROP checkup. One
Yes,
part
exactly.
is to learn the definition, learn the classification, the exam point of view. 1,500 grams, 2,000 grams, 32 weeks, 28 weeks, all those numbers you need to know the exam point of view. But from practical point of view, while as a practicing ophthalmologist, even if you are not doing ROP screening yourself, or the center that you're working at does not do ROP screening, it is very important that if a pediatrician friend calls you or a relative calls you and has some idea about this, you should be able to say that if the birth weight is less than 2 kgs and a baby was born prematurely, speak to your pediatrician, speak to your neonatologist, and have the checkup exactly 1 month after birth. I think this, from the practical point of view, is I think the take-home message for us. Dr. Pranab, am I correct, or do you want to change anything what I've said?
No, no, exactly, exactly. That's what I want to say. I wanted to say. Many a times we see even the ophthalmologist. The baby came to ophthalmologist. The ophthalmologist said the baby is too small. Bring the baby once the baby is big enough. That is a very I think disastrous thing to do. We have seen babies who is coming at 5 months of age with stage 5 ROP blind baby, though the baby has attended the ophthalmologist at 4 weeks. So it is very important to examine. First examination should be done at 30 days or 4th week of birth. This should not be missed. So can I go for it, sir?
Please go ahead. Please go ahead.
Yes, sir. Yes, sir. So how long we should screen the baby? Suppose we have examined the baby on first time, and then we will decide whether the baby requires further examination or not. If you see the baby, the retina is wholly vascularized, no need to examine the baby again, or the baby has reached a stage where the laser is required, we do go for a laser. Now, how do we dilate these babies? We need to dilate, do pupillary dilation. Here we use tropicamide 0.5% with phenylephrine 2.5%. In a commercially available drop, there is 0.8% of tropicamide and 5% of phenylephrine. So if you dilute it to by 50%, adding tear substitutes, refresh tears, then it will come to this required concentration. We should never use the adult concentration of drug for the babies. And if you use cyclopentolar, we'll use it for laser. Here you will again dilute it to 0.5%. And atropine should never be used in babies. Where should examination be done? See, well, the babies are with the NICU or critical care unit, baby should be examined there. Once the baby has been discharged to the and has gone to home, they can be examined at neonatologist or ophthalmologist office. Only thing, place should be warm enough and clean, and place should have basic resuscitation equipment. Examination procedure: the people should be dilated 30 minutes before examination, and they should receive feed and buffed an hour before the screening. At least half an hour of or half to 1 hour of NPO is required. Baby should be well clothed and wrapped.
Dr. Pranab?
It's not moving. Slide is not moving, sir.
Okay, even these two below the baby have shown two instruments over there.
Yes, sir.
Yeah, can you elaborate on those?
This is called Alfonso speculum. This is longer blade. It's easier to insert and remove from the eye, and a very small one. And this is a small vervectis with round tip, round this thing. Small vervectis basically. This you use to open the eyes, and this is to rotate the eyeball so that it helps us to examine the periphery while we are doing the indirect ophthalmoscope. This.
So you would recommend to specifically use these two? These are very easily available. I think at all
Yes,
meetings, AIS, everywhere these are available. Preferably not to use the routine ones that we have in the OT. And these specialized ones should be used because the baby's eyes are very, very tender. And one should get these. They are very cheap. They have nothing. They are not very highly specialized things. To use the normal speculum, to use the normal wire vectors, I think it's not a good idea. It's better to use these special ones. They're very cheap also. Right. Are your slide moving now?
It's not moving, sir. I'm trying.
Can we request everybody else to please mute your mic? Please mute your mic. Can the admin mute everybody and then Pranav and Saurav can unmute themselves?
Yes, I will mute all. Now the speakers and moderators, they can unmute their mic.
Dr. Saurav, you were able to start your computer again? Dr. Saurav?
Yeah, Dr. Pranav slide is, yes, sir, slides are visible. Dr. Pranav, sir, can you unmute your mic? Yeah, Dr. Pranav, can you upload the slides?
Even I don't know what happened to all of you, but I got totally disconnected.
Okay, sir.
Okay, we were looking for you. Good, you're back.
Dr. Sushma has again asked for YouTube link. Dr. Sushma, let me share with all the postgraduates. With the Microsoft Teams, they are not able to have a YouTube ongoing at the same time like in other presentations or a Facebook Live. But this meeting, once it finishes, it will be edited and a YouTube will be put. The link will be given to you. The previous 4 or 5 talks that we've had are all available on YouTube. You can contact Intas and Dr. Satyajit Sinha, isin@gmail for the connections. Yeah, we are back with Dr. Pranab. Fantastic. At least half the slide can be seen.
So I have
Yeah, can
received
you hear me
a
also?
lot.
Yes,
Yes,
Pranab,
Pranav,
we
we can hear you. I have received a lot of requests from postgraduates for YouTube links. This Sunday, I'll be sitting and sending the YouTube links to everybody. So if you haven't received a reply from me, don't worry. I am going to send a reply to each and every postgraduate this coming Sunday. I was busy with a few other webinars, but this Sunday I'll reply to everybody. I'll send every postgraduate who has written to me on eyesinha@gmail.com. I'll send everybody a copy of the YouTube link right from day one, from the squint classes to all the classes that will happen through this week. Dr. Pranav.
I have a suggestion, Dr. Satyajit. Of course, that's a great work that you're doing. Why does Intas not on the starting of every chat of every meeting like today's at the end, beginning and at the end, not put all the YouTube links here in the chat box? You can do that here also.
Sir, yeah, of course, sir. We are putting up the link of day wise, sir.
Yeah,
And
like Manish
yeah,
has just now put. He's just now put. He's just now
yeah,
put.
yeah.
Day 4 link.
Earlier days also we have uploaded in the chat, so we are getting the views. As I can see in the background that more than 125 people they have already viewed the day one, day two, and day three sessions.
Yeah. Now,
So
I would
yeah,
also request Manish to coordinate with Dr. Satyat and me day 4 and what class it was. So if somebody wants to know what was on day 4, the class over there, which is average, whatever, so they know they want to see it or not.
Okay. Okay.
Yeah.
okay.
Okay. We'll figure that out after the class. Dr. Pranab,
Okay.
can you continue, please?
Yeah,
So,
yeah, yeah.
sorry. One second. Dr. Venkat has posted a question, sir. Can we have a class on B scan, please? Dr. Venkat, since you said that, I have a few slides today on vitreous hemorrhage, RD, PVD, the simpler component ones. I will try and do that a little bit detail. Of course, I'm not going to talk about tumors and things, but simple vitreous hemorrhage, PVD, RD, I think I will try and cover today a little bit more in detail than what I had planned. I will try and answer those questions of yours, Dr. Venkat. I'm sorry, but Dr. Pranav, can we go ahead, please?
Yeah, okay, sir. So coming to the treatment part, so what is the indication for treatment? This is given by the RD treatment ROP or ET-ROP. They have recommended to treat the ROP if the disease at zone 1 and the stage of ROP is 3. Even if there is no plus disease, we have to treat. And any stage of ROP, say 1, 2, or 3 with plus disease, if the disease at zone 1, you have to treat. And if the disease at zone 2, only stage 2 and 3 has to be treated if there is a plus disease. So this is the recommendation, ITROP recommendation for treatment. Yes,
Can
sir.
I make this easy? Can I
Easy,
make
yeah. Yeah.
So for the postgraduates, any patient, see, I know at your level you're not seeing RFP babies or the places that you work in may not be having too much RFP examination, but you get a concept in your mind. What Dr. Pranab has said over here is any disease where the baby has been premature, has had a stormy course, has had some uh, need for blood transfusion, has had need for other treatments, has had septicemia, has had cardiac issues, has had respiratory issues. These are babies who will need treatment. These are babies who should be examined for ROP. So those are systemic factors. In the eye, any disease around the disc in the posterior pole, whether it is tortuosity, whether it is more than a range of fibrosal proliferation, so any disease in the posterior pole, for you to understand, that means this is aggressive ROP, and I use this aggressive word from the AP-ROP studies also. So from the postgraduate point of view, anything which is very anteriorly, very mild, people dilate it very well, can see the retina very well,
Yes,
it's a
need not
milder
to be
disease, need not be treated, and can be followed up. So initially, he said the percentage is 60%, 70% in the beginning. I wanted to understand that that's the numbers given for all
in
premature babies. And in India, the numbers are a little bit less. Again, we don't have too many studies from India. We have some good studies from PGI Chandigarh group, from Shankar. They have done a good study also. But the point here is that in your mind, please have a concept. ROP is a very, very important disease. As a postgraduate, not just as a short note or long question, but from treatment point of view. Unfortunately, not too many retinal surgeons also treat ROP. A lot of our colleagues are trained retinal surgeons, do a lot of surgeries, do a lot of high-end laser injections, but a lot of them are not trained ROP people. So there are not too many people, ROP people, in the country as such in India. Uh, Pranab, you have the ROP Society, which you all have formed around 3-4 years back. How many
yes, sir.
members in that? How many members in that approximately? Approximately.
Now approximately 200 members are there.
So 200. And
200.
that's, and unfortunately all 200 are possibly at least half of them or even more than half of them are centered in just Delhi, Bombay, Calcutta, PGI, Chandigarh, or some AIMS,
Yes,
Delhi, or
yes.
something like that. So I would encourage that those of you who are finishing ophthalmology training, and even if you don't take a retina training, but at least be interested in ROP, because it's something where we are lacking horribly. I think the talk in ophthalmoscopy was very important, and I think this talk on ROP is there only to motivate all of you that this is a disease which is very untreated. Phaco, lots of people can do very well, But believe me, most ophthalmologists, most retina specialists cannot say ROP very well. So my request, challenge, motivation for all of you today listening to Dr. Pranav Das, that this is something we all need to look at very, very. It's our duty to the babies and the future of this country. I know I sound like a politician, but I just cannot help by saying that. We move. Sati, anything to say on that? I'm passionate. I'm passionate about this. I see lots of blind babies. It's a sad thing. It's very sad.
Correct.
We see lots of babies are
What
there
you're
6
saying
months
is so true.
before your white reflex, and it's so sad. Parents walk in before examining, you see the white reflex, you know there's nothing you can do for them, and it's so sad. And they had no idea what had happened. Nobody had told them. No ophthalmologist, no physician had told them. So I even tell people, my colleagues, that those of you who are ophthalmologists who don't do ROP, at least go to IIM meetings, go to other meetings, and talk about ROP a lot. That's very important. Sati, any comment on that?
So my comment is, suppose I am in a place like Bhagalpur or somewhere else where there is no ROP specialist, and this kid which is born premature really cannot afford to travel anywhere, or let's say even the baby is in the NICU, and the parents cannot afford. The child's physical health is also sometimes an issue when ROP is there, and the child may not be able to travel. What do you do in that scenario? In cities and all, it's okay that the specialist goes to the NICU and sees the patient. But in places like you are saying, it is so undertreated, and that is mostly because there are not enough doctors for ROP. ROP specialists are not there. That is one of the major contributors for ROP blindness in India. So if I'm in a place like where there is no ROP specialist, what is your advice for that scenario?
That's precisely what I said. Today's PGs who are listening to us should take this up as a challenge. Learn FACO and learn ROP screening. That's precisely what I'm going to say. It should come as natural as that. The urge to learn FACO is so high among all ophthalmologists. I'm not saying cataract surgeons. Is so high. Why is the urge not to do ROP? Is that because, like Dr. Pranab said, that in that 50% and the 30-40% of premature babies who have ROP, 5 to 6% need treatment. So that's a huge number. And ROP is not going to go away because our pediatricians, neonatologists are doing a great job, but we are not supporting them. And mind you, with Dr. Subhadra Jarali in Hyderabad has shown how she runs from NICU to NICU in Hyderabad and how many babies she saved. She has a huge data. I will be quoting her also, and she has shown what she can do. A single person like her has done such a big thing in that city. And I know Pranab has done it. Dr. Pranab Das has been going for the last 7 years to the medical college on his own, no pay, no nothing, twice a week, 3 hours each week, just to see babies and treat babies. No pay, not a single paise he has got in 7 years.
Really commendable.
So, my one comment to Dr. Satyajit Sinha's question. So if there is no anybody to see the baby, okay, so at least we can try to see the posterior pole. After dilating the pupil, if you can see the posterior pole, and if there is no gross abnormality, say a dilatation or tortuosity, gross dilatation tortuosity is not there, so baby can be waited for another 1 or 2 weeks. By that time, once the baby come out of the NICU and baby becomes little small, little bigger, then baby can be shifted or referred to other places, maybe 100 kilometers away from your place. Okay, that much we can do at least.
So my thing about this is that if these ROP specialists reach out to all the small towns,
yes, sir.
and once they get a call from somewhere with this red cam, they can send their optometrist to these small towns, and from there, from the red cam, they can take pictures and do telemedicine, and something can be done about that. If the treatment part is there, that is the part two to be dealt with, but part one is diagnosing. So maybe the optometrist can travel in a train or bus or something and go to that place with the red cam and do some screening and send some
nowadays there are Indian cameras also, which are cheaper camera, 15-16 lakhs camera. One can be, I mean, optometrist, even a non-optometrist like plus 12 pass can be trained for taking the fundus photograph, and they can transmit it to the specialist, and then and there they can report it and just call the baby after 1 or 2 weeks according to the stage of the disease. That can be done, and many centers are doing now. The Bangalore, Naranetra Bangalore, they are doing.
So I was going to say that it needs motivation. Why did I bring this up is exactly what Pranav is saying, and what you said is for the newer ophthalmologists, for the younger people, they should take it up because Karnataka has shown, Bangalore has shown how vans go around. Netra, that is an Nara Netra, Dr. Anand Vinekar, Dr. Praveen Murthy, their group of people, Retina Hospital, they do yeoman service. We are definitely lagging behind in other parts of India. The way they have shown in Karnataka, southern Karnataka is very nice. I think leave it at that. There is a question from Dr. Kapil. Why same screening time 1 month after birth in preterm 27 weeks or 32 weeks? Dr. Pranab, I'll repeat the question again. Why is same screening time 1 month after birth in preterm baby 27 weeks or 32 weeks?
The answer is here. See, if I see 100 babies in India, the say 6 babies will require laser. Now, out of these 6, 2 will have aggressive posterior ROP. Now, the smaller the baby, say lesser than 1000 grams, 1200 grams, or up to 27 weeks, if the gestational age at birth less than 27 weeks, they are more prone to develop APROP, and they reaches the stage of requiring treatment at early stage. That means at 3 weeks of time. So we don't want to delay. If I miss the disease at 3 weeks, by the end of 4 weeks, the retina may have been elevated. There is already retinal detachment. So to detect those APROP babies who develop early in a smaller group of babies, those who are really sick, let's say 27 weeks or lesser, 1200 gram or lesser, they can develop disease earlier, say at 2 to 3 weeks. So we should pick up the disease at this stage, and we should do laser or injection, whatever required, promptly. That is why this differentiation of this initial examination.
Dr. Kapil, to make the answer easier, I agree with the logic you have gone forward that for every week there should be a different age that you should see it at. But please understand, the more you complicate the recommendations, the lesser they will follow rigidly. You'll miss patients in that. So I agree that for 27 weeks, 29 weeks, 32 weeks, it should be different ages. One may be 28 days, one may be 32 days, one may be 27 days, and that is how we should have a titration. But the 30 days, 28, 4 weeks, 28 days sort of covers all these age groups. That's the answer also from a more practical point of view. I hope I've got my point, Dr. Kapil. Thank you. It's a very nice question. It's a very, very important question. At least he's thinking about it. I'm so happy for Kapil and for all of us. Can we go ahead? You're already at 5:50.
Yes, sir. Yes. So what are the treatment options? Laser photocoagulation, laser photoablation is the standard of care till today. And the other options are intravitreal anti-VEGF injections, cryotherapy, not done nowadays for only historical importance. And the baby who has reached beyond stage 4A, B or 5, they will require surgery or vitreoretinal surgery. So coming to the laser photoablation, it should be preferably done at an ICU. We can use either diode laser or 532 laser, and we have to put confluent laser, each laser one touching other one. The need to laser whole of the avascular retina. The posterior vascular retina we should not laser. We should apply laser to only the avascular retina, that is anterior retina, which is not vascularized. In India, most of the laser is done under topical anesthesia, and after the procedure, we give topical steroid and antibiotic for 7 days. And little bit about the intravitreal anti-VEGF injections. This is done as a rescue therapy in severe APROP, and in case of with the laser has failed, and before vitreoretinal surgery to reduce the vascularity. The limitations are, we don't know the long-term ocular and systemic side effect of the intravitreal injection. Sometimes, if there is vitreoretinal traction, it may be worsened with the injections. So here we use half to 1/3 of the adult dose. So the outcome here, almost 95% chance of regression in classical ROP and 75% chance in regression in APROP. So the APROP bears the poor prognosis. What are the adverse effects? Properly done laser doesn't have. I haven't came across any serious adverse effect. If it is not done properly, there may be cataract formation, there may be ocular ischemia, choroidal detachment, and glaucoma. Cryotherapy is the historical importance only. There are few cases you can see in the left hand side top photograph. There are stage 3 ROP. The vessels are dilated tortuous. There are retinal hemorrhages. Here you can see the post laser. The eye became quiet. The vessels dilatation tortuosity has gone. There is no retinal hemorrhages. We can see it at the temporal periphery. These are the laser scars. This is the APROP zone 2 posterior, pre and post laser. This is severe APROP. This managed to intravitreal injections followed by laser. So in conclusion, all babies with birth weight less than 2000 grams and period of gestation less than 34 weeks should receive ROP screening. First screening should be done at 3 to 4 weeks after birth. Only diluted eye drops to be used for pupillary dilation. It is important to recognize ROP with the atypical features like APROP, and laser with indirect ophthalmoscopy is the current standard of care. Thank you.
Thank you, Dr. Pranab. I just had a small